Hey, Chris. Hello.
Hi, can you hear me okay?
I can. Yes, thank you. Thanks so much for joining us today. Really excited.
Yeah, thanks for the invitation.
Yeah, of course. Give it a few minutes as people start to roll in.
Okay.
Hey, Chris.
Hello.
Hey, Ron, how you doing? Good to see you.
Yeah, good to see you. Thanks for coming.
And Chris, are you able to screen share?
Yeah, I'm gonna do it right now
Okay, I
here.
just want to make sure that it works for
Right.
you.
Are you seeing the
Perfect.
full screen? Okay.
Yep, it's perfect. Well, in the interest of time, go ahead and get started. All right. Well, it's my honor to present Dr. Chris Cielo from the Children's Hospital of Philadelphia, where he's a pediatric pulmonologist and sleep medicine physician and director of the Sleep Center. And he's an associate professor of pediatrics at the University of Pennsylvania. His clinical work and research program focus on the evaluation and management of obstructive sleep apnea in children, and he has a particular interest in high-risk populations, including children with Down syndrome and craniofacial differences. He is currently PI for an NIH-funded clinical trial and site PI for several multi-site trials. He has served on committees for multiple national organizations, including the American Thoracic Society, American Academy of Sleep Medicine, American Board of Internal Medicine, and Children's Hospital's Neonatal Consortium. At CHOP, he is a member of the IRB, directs Sleep Research Core, and is co-lead of the Sleep and Circadian Research Affinity Group. In his free time, he and his wife enjoy cheering on their 3 school-age kids. So, Chris, we're so happy to have you here today and really excited to learn from your talk. So, I'll turn it over to you.
Well, thanks very much for the invitation. And so I was asked to talk about pediatric obstructive sleep apnea. So for an audience like this, where you guys have one of the top sleep centers in the country, trying to balance providing some clinical background for those who don't do as much pediatrics with just some of the stuff that's going on in the field right now, which I think is really exciting. And some of that includes collaborations with your own center. So it's a great time, I think, to be in this area. So no conflicts. You talking about some research as was mentioned. Some of this stuff's been funded by NIH and otherwise. And so we'll be talking about some off-label kind of use just in the research context right now. So I thought I would sort of divide this into 3 areas and then hopefully have some time, for some discussion at the end. But first, focus really on the evaluation of pediatric obstructive sleep apnea with a little bit of background, but not too much. And then some of the research that's going on at our center and some of the work I'm involved with home sleep testing. Second would be management, and then again, some of the current options we have, and then really focusing on that management in the area of Down syndrome, which I think is really the population that's pioneering a lot of the interesting work in this space. Not all of it, but some of the interesting work. And then finally, just to make some comments about the workforce in terms of pediatric sleep medicine and I think some of the challenges that we're facing right now as our field grows and expands. So just by way of sort of very general background, as you know, sleep apnea is common in kids. Affects maybe up to 5% of children, with maybe twice or maybe 3 times that many having sleep disorder breathing, if you expand the definition. We know that kids with obesity and adenotonsillar hypertrophy, like this image here, are at high risk. Also, at our center, and probably yours as well, we see kids with different craniofacial differences, like this boy with hemifacial microsomia and others. And there's lots of other risk factors that you're probably aware of, including conditions that cause hypotonia, broadly speaking, babies that are premature. And I know your center has done a lot of work with infants and sleep apnea. And we know that, in general, Sleep apnea in children, probably everybody, includes both neuromotor factors, which cause airway collapse, and then upper airway anatomic features, like some of those that we've mentioned, and otherwise that really lead to the risk and then the severity of sleep apnea in kids. So it's not just looking at the size of the tonsils or their hypotonia, but it's really a combination of the two. And that's what causes some of the challenges and what leads to some of the treatments that we'll be talking about. One of the most common treatments, one of the most common surgeries in children really is adenotonsillectomy. 300,000 to 500,000 of these surgeries done a year, and now the main reason for those actually is obstructive sleep apnea. So this is something that's being done very, very commonly. And we know from some of the work that's coming out of that's come out of the PAT study, for example, that even mild sleep disorder breathing really can have significant impacts on kids. It was really striking to look at some of those findings from that paper that came out a couple of years ago, including quality of life and behavioral symptoms, broadly speaking. And these are just some other data from different pediatric studies looking at consequences of sleep apnea, just to show that this really does impact kids. The top figure here is one of the supplemental papers from the CHAT trial. And you can see in red bars, even if you can't read this, this is those who had watchful waiting versus the blue with early adenotonsillectomy. And you can see that there were significant improvements in things like sleepiness, quality of life through the PedsQL, like symptoms of sleep apnea with the OSA 18, and so a number of other outcomes. This is a meta-analysis that was done looking at some more behavioral consequences, showing the relationship between sleep apnea and depression that was pretty consistent among these trials. And then this was some work that was done a number of years ago looking at some of the consequences in terms of lipid metabolism, glucose, and otherwise, and inflammatory markers, and a cohort of obese and then non-obese school-age kids. So really impacts kind of across multiple systems. And we know that polysomnography is the test that's recommended for pediatric obstructive sleep apnea. It's the gold standard for a number of reasons. It's, as you know, continuous multi-channel recording of sleep and wake. You get so much information from this. It's really a plethora of data in terms of gas exchange, physiologic parameters. Not only can we diagnose sleep apnea, but also other conditions that are important. And we can really clearly determine whether the severity is, what the severity is, as well as the diagnosis of sleep apnea. But there are some definite challenges to polysomnography. You guys have a big sleep center, and where I am, there's one as well. But in many areas, it's just not available, especially for our higher risk or more complex patients, and especially in pediatrics. And even when there are sleep labs, like we have a 22-bed pediatric lab, and we still have very long wait times, which is unfortunate. We still get cases of kids who have waited many months and have very, very severe sleep apnea. And it's a real challenge. The testing can be expensive in terms of just expanding and building your lab, hiring people, and then some families get stuck with very high copays. We know when we try to enroll patients in some of our studies, this comes up a lot of times in discussion, the cost of getting the studies. It can also be inconvenient if you have a single parent who has multiple kids. Usually they can't bring the rest of them to the sleep study. And then kids, especially those with special needs, they may really struggle just being in a hospital environment at all, especially overnight, if they've had other treatments that they've needed in the hospital. And kids with developmental disabilities, they just may not understand the kind of testing that's needed and the different sensors and things like that. So it can make it really tough for families. And we know that, from research that's been done decades ago, that home sleep testing can be done in kids. Obviously, this is being used as part of clinical assessment in adults. And these were trials done in the 1990s and early 2000s. There were two main studies, both that included EEG, done in about 200 kids each. So there were like 400 total. Most of them were technically adequate, although the nasal pressure channel was probably the most problematic because kids will pull that out in the middle of the night and then the parents had to replace it. So it can be done, but these studies didn't compare the results of this test with polysomnography, and they really didn't look at any parent outcomes. So it's not really clear, although it can be done, like how useful it is and whether parents really like this kind of test. This was a study done about 10 years ago by David Ghazal's group, where they just simply took 100 sleep studies and they removed the EEG. And what they found was that without that signal, they misclassified about 25% of the sleep studies. They looked at like no OSA, mild, moderate, and severe sleep apnea. And the hypothesis here was that you're really unable to distinguish between whether the child's awake and asleep during that part of the study and whether or not they're having arousals. And then there have been a number of studies, especially during the earlier days of the COVID pandemic, which looked to see whether we could, do home sleep testing compared with in-lab polysomnography. And this was one done by the group at Texas Children's, led by Amy Ravana. And they looked at really adolescents in this trial. So they had 38 mostly obese adolescents who were doing type 3 home sleep testing, so with no EEG. And they found that there was a good correlation between the results of in-lab polysomnography here on the x-axis, and then the home-based sleep study, the HSAT test on the y-axis here. But there was a big difference between the two. So the difference in OHI between the two is about 15, which for children, could be the difference between not having sleep apnea at all, and then depending on your lab, like having more severe sleep apnea. And there was a huge, area in terms of the limits of agreement, like -32 to 62. So there was just, even though they correlated, it was just really hard to know what that value actually meant. And so they had to use a lot of post hoc analyses really to be able to determine moderate to severe OSA. It's just one study, but there were several others done during this time that had similar findings. So for these reasons and others, currently, as you may know, the American Academy of Sleep Medicine just does not recommend doing home sleep apnea testing as part of the evaluation of sleep apnea in children. And in this paper, which came out in 2017, they cited that there really just wasn't a lot of evidence comparing these two tests. Very few studies at that time really had done this. Most of them didn't include EEG, so that may have been a limitation. And then a lot of these studies really didn't include kids with comorbid conditions, which you probably see a lot of in your clinic. So, it would really need to be a test that could be usable by not just really otherwise healthy kids. And they really just didn't look at things like parent and child factors. And if you're going to have a test that's going to work in children, you have to have something that the parents are also going to agree with. It's not just giving the child the equipment to take home with them. The parents are going to have to monitor it. So, we see this as a real big challenge in our field because I think it limits, at least it's one of the limitations in terms of the size of the sleep lab with how many kids you can evaluate. It doesn't really get to the fact that the physicians are the ones reading the sleep studies and are still required for it. So we designed kind of some studies thinking this through, and I'll go through a few of them in detail. So this was the initial sort of pilot study that we did. But the overall structure of these studies is going to be similar, where we were really looking to look at feasibility of home sleep testing, in this case with EEG in children, compare the accuracy of that test with polysomnography, and then we really wanted to, again, get a sense of these parent-child preferences and their feedback. So this is a picture of a child who was wired up for the tests that we did, and we used basically like a full home polysomnography kind of system, mostly because we just wanted to have the data so we could go back and choose what data we wanted to use. So we've got the inductance plethysmography belts, as you would have in the sleep lab. We've got a full EEG. We've got the cannula with nasal pressure and thermistor. We have a Bluetooth pulse oximeter here. There's EKG underneath the pajamas there. So we have really all the sensors we'd have in the lab, except for video. We don't have the limb leads. And so we kind of got most of this. So we were recruiting kids who were already being referred for in-lab polysomnography, and we would have them do the in-lab test as part of clinical care, and then we'd get this home sleep test. And we had them basically fill out a bunch of questionnaires, like what did you think of the test? Which one would you prefer? How easy was the test to do? And so this is some of the results from this pilot study we did, which only had 15 kids, that was published on JCSM just a couple months ago. And so we really were trying to get a broad swath of kids. So we had ages like several kids that were just 2 and some that were adolescents. We felt like the race and ethnicity kind of data was exactly what we're looking for, sort of a wide range. We didn't have kids with specific underlying medical conditions that we recruited, but we did have kind of typical comorbidities in terms of obesity and other common childhood conditions. This was tough to do. I mean, the families really struggled in some cases to keep the thermistor and the pulse oximeter on, as kids would kind of wiggle out, especially younger kids. So you can see in only half the studies did we have, or we only had full data in about 53% of the recording. So that was a challenge. The chest and the abdomen and the EEG were incredibly stable, like almost every single patient, it was fine. But the nasal pressure and the pulse oximeter did come off in some of the cases. So we looked to see in terms of correlation between the two tests, and we found that out of the 15 we had, 14 ended up with a diagnosis of obstructive sleep apnea that was the same as that which was happening on polysomnography. And these were done on 2 different nights. So there was that night-to-night variability that potentially could come up to. There was only one participant who had a different diagnosis when we used an AHI cutoff of 2, which is what they used in the CHAT trial and some other studies. And we actually had them do, when they did their in-lab test, we wired them up with the same portable equipment because we were sort of checking in lab. And even in that one, there were some issues in one of them. So we didn't end up with the same diagnosis. But otherwise, they were very similar in terms of the OAHI. The values were very similar between the two tests, the central index and all the other sub-indices that we looked at. When you correlate the two, they had a very strong correlation, and the p-value was pretty good too. So we have the same axis. It's always important to look at the axes here because sometimes they go up. One goes up to 100 and one only goes up to 20. But this is the PSG on the x-axis and the home sleep test on the y-axis here. And then we wanted to even further investigate this a little bit just to see, okay, well, that's what the diagnosis of AHI of 2, but what if you were to break this down even further into like AHI less than 1, 1 to 5, 5 to 10, and then greater than 10, which isn't the designations that we use in our lab for mild, moderate, severe, but we know that this is what a lot of places use. And I was surprised to see that if you compare the home sleep test done in the home environment to in-lab polysomnography here, there were like 8, I think, if I count correctly, that were different. And I was like, this is really inaccurate. But then if you go back and look, you see that 4 of them overestimated slightly and 4 of them underestimated. And then if we compare with the 2 tests that were both done simultaneously in the lab, it's much closer. So there were only 2, one with a little bit higher and one with a little bit lower, which tells me that this test is not biased toward like underestimating sleep apnea or overestimating. It's just that there's some night-to-night variability here. Small night-to-night variability because you may cross this threshold of 5, so go 4.9 to 5.1 or 0.9 to 1.0. It's just not realistic to expect that you're going to get the identical number on different nights. So we felt pretty good about that. And that there's just, if you repeat the in-lab polysomnogram several times, you're probably going to get slightly different numbers in some of those cases. And when you look at the Bland-Altman plot that we had from our in-lab versus home sleep test data, again, the numbers are pretty close. As you get to higher AHIs, there were definitely some outliers though. And so we looked at sensitivity and specificity using these different thresholds. And you can see it's very hard when you have an AHI threshold of 1, your specificity gets very low. But with an AHI threshold of 2 or 5, which is probably more realistic in terms of treatment, we felt like it was pretty good. We did ask about preference. This wasn't published in that initial paper, but we're working on it for future publication. And it was very mixed. We were sort of surprised. Some of the families definitely preferred in-lab polysomnography in the orange here versus those who preferred home sleep test or felt like it was easier. And this was true both for kids and parents. So I think it's important to realize that even if this test was perfectly accurate, it's just probably not for everyone. And there can be lots of different scenarios at home. Some of the families found it very stressful, challenging. They said it was like a long night. They were like up all night with their child. But others who really preferred it did find that it was more accessible and convenient for them. So again, although most found that it was pretty easy to use, like some would rather just come in the lab if they had the choice. So we thought that was important feedback too. We had 2 of our graduating fellows who presented some data at the sleep meeting last year, where they basically rescored all of the home sleep testing studies without EEG. And again, similar to that Ghazal study, what they found was that this did create a significant bias. So as the AHI goes up, the difference between the PSG and the HSAT without EEG gets higher and higher and higher. So you can see that there were 40% who had an OAHI greater than 2 when you had the EEG, but when you remove that, it goes down to like 12 or 13%. So there's a definite difference there. We need to look at this in more detail, and with a bigger cohort, this is only 15 kids, but just something to keep in mind when we're thinking about, if we were to do home sleep testing in kids, like what channels are actually important for the diagnosis. We did a similar study that was published a couple of years ago in youth with Down syndrome. This was funded through one of the early Include R21 studies of my colleagues Andy Kelly at CHOP and Ignacio Tapia were able to get. And so this was tricky because we got funded right before COVID. We were still able to recruit 43 participants, And 40 of them were able to complete both the home sleep test and the in-lab sleep study, which was a little surprising. We actually thought that they were going to have more trouble. This was a pretty complicated group, as those who work with Down syndrome know. A lot had a diagnosis of autism. There were a lot of other comorbid psychiatric conditions that made it challenging. Most of these were adolescents, so a little bit older than the study I just presented, and most of them did have obstructive sleep apnea, as you would expect to. And one of the interesting findings was that they slept significantly more in the home than they did in the lab. And so these were the same kind of questions that we asked in that pilot study that I mentioned. And what's interesting here was that most of the families in this case actually did prefer the home sleep test compared with in-lab polysomnography. And almost all of them found that the home sleep test was easy to use. They welcomed it. They felt like it was usable. So I felt like here, and it's interesting to compare people with Down syndrome, families with Down syndrome, to those who do not have Down syndrome, because again, the findings may be very different. And it's just useful to know that there may be populations of kids where one diagnostic treatment or one diagnostic tool or one treatment may be helpful, where it may not be in another. These are the same kind of Bland-Altman and correlation plots. Accuracy of the home sleep test in this case was 80%. So not perfect for sure, even with the EEG, but pretty good. And again, you could see that as the AHI and the Bland-Altman plot here gets higher, you get more and more discrepancy between the two tests. Again, some of these were patients where they pulled off the equipment in the middle of the night, made it hard to score. We didn't throw those out. We included everyone in this just for real world kind of examples. And others were ones where there may have been more of a discrepancy or that the testing just didn't work as well. One of the interesting things that we found in this study was that there were two participants who had a normal in-lab polysomnogram, but definitely had, I think in both cases, moderate obstructive sleep apnea that was diagnosed at home. So whether there's something going on in the home environment that may be more realistic to what's happening versus the lab, like environmental exposures, for example, or sleep position, is something that needs to be explored a little bit more. All right, so there's two ongoing studies that I'll just highlight that are kind of using some of the same methodologies. This one is funded by American Academy of Sleep Medicine, and this is really looking to see of all these kids who have adenotonsillectomy that we don't reassess with any objective testing. Like, could home sleep testing be something that's useful in this assessment? And so my colleague, Dr. Lin, Nancy Lin's helping out with this, one of our sleep physicians, and then biostatistician Darko Stefanovsky, who's been really involved with a lot of this work. We just completed recruitment actually last week. So we actually recruited, consented 62 kids between age 5 and 12 who've had endotonsillectomy. And again, same kind of design. They had a clinical sleep study that they were referred for, and then they had the home sleep test, as I have already described. And then we had them complete a bunch of questionnaires, including the OSA 18, the Pediatric Sleep Questionnaire, and others, to see whether their symptoms matched the results of the home sleep test, and then obviously whether or not it matched with the in-lab PSG. So we don't have the full results of that yet because we just finished recruitment, and we'll be hopefully sharing that soon. We're planning to prepare an abstract for the upcoming sleep meeting. Yaelis Roman, our lead coordinator for this study, did present some of the preliminary findings at a sleep meeting last year. And similar to what we showed before, the kids with the home sleep test slept significantly more, 492 versus 420 minutes. They had less wake after sleep onset at home versus in the lab. And the rest of the parameters, like in terms of OAHI, were like very, very similar. So again, this was only half of the cohort, so we'll have to wait and see what we find with when we have the full results. And again, just like I showed in the other study, we did have several kids where OSA was found only on the PSG, which is in this gray. And then there were 4 in that group, and then 2 where OSA was diagnosed based on this OHI cutoff of 2, just with the home sleep test, but not in the lab. So again, some night-to-night variability, but most of them basically had the same finding. And then the last one I'll mention in this area is one that's funded by an NIH, R6133, which is ongoing. This is one we call HATCH, which is kind of comparing, again, home sleep testing within lab PSG. This is including a cohort of kids with Down syndrome, as well as that's 100 kids with Down syndrome and then 200 kids who don't have Down syndrome. And I'll just point out that the one aim that's a little different here involves these 3 colleagues, Lourdes Del Rosso, Angelique Gallion, and Sally Ward, who are really looking to see, okay, forget about what the AHI is, like, does the doctor basically make this same clinical decision. So we basically send them the information about the participant with the results of either the home sleep test or the in-lab polysomnogram and say like, okay, would you refer this patient for adenotonsillectomy, or would you just do conservative management? And we're looking to see, is there difference in therapeutic decision making between the two tests? So the AHI discrepancies may be small but cross some threshold, but does that actually affect the care? Because we feel like this is really important, in terms of whether the results of this test could actually affect the treatment decisions by clinicians. And then the last thing I'll just mention about this is that I'm a part of this American Academy of Sleep Medicine task force. There's an adult task force that's happening concurrently, but we're just reevaluating the evidence since the 2017 guidelines came out. And this is a really great group to work with that's led by Lynn D'Andrea from Wisconsin, and other membership includes the folks you see here. So Dominic Galt from South Carolina, Chrissy Hybe from Cincinnati. This is Anne Marie Adams, who's actually a research scientist who has a sleep tech background that's based out of Australia. And then Anuja Bandiapathy from Riley, and then Carol Rosen, who's been working with the ASM. So it's been a great group, and we've been kind of working to look at all these the literature and try to come up with some guidelines. But I think that this probably will be somewhat controversial, I think, regardless of whether this committee decides that this can be used or can't be used. And I mean, our paper that came out, this very small pilot paper, did have an editorial in JCSM that was published, like, we probably can do it, but should we? So, I think whenever this comes up, there's a lot of controversy and people have different feelings about it. So we'll see what ends up happening in the field. All right, I'm going to switch to talking about management, and just start off by mentioning, as you know, adenotonsillectomy, I've already said, is the main treatment for the first-line treatment for sleep apnea in children. We know that there are some groups that are higher risk and may have more challenges with this. So those who are younger than 3 years old, those who have more severe OSA may not have resolution of it. Those who are currently sick, kids who are obese can have more complications, and then kids with craniofacial anomalies also may not have resolution of their sleep apnea. We know that there can be complications in any procedure, even if they're rare, that's done hundreds of thousands of times, you're going to see these kinds of things come up. And so pain is probably the most common. We see kids come in with dehydration, complications from the anesthesia itself, sometimes acute upper airway obstruction in those with severe cases. In the PATS trial that was just published a couple of years ago, there was a risk of significant enough hemorrhage that these kids needed intervention in 2.7%. So again, not super common, but when you're doing it hundreds of thousands of times, it comes up. So there definitely is a need for other therapies. And as you know, that there are can be OSA that's persistent after adenotonsillectomy. In the CHAT trial, there was resolution of about 80%, which is pretty good, of sleep apnea after adenotonsillectomy. But if you looked at some of these subgroups, like the group of Black children that was involved, it was lower at 71%. In the obese group, it was 67%. And then if you just look at the severity of sleep apnea as you get greater than the median, or as the sleep apnea gets more severe, the rate of successful treatment goes down. There was another study done by Rakesh Bhattarji. There was an older study from like 2010, which showed only about 27% in that cohort actually had complete resolution. So that wasn't done as part of a research setting. And you can see that here. And things like obesity and OSA severity kind of could affect that outcome. And then we know that in kids with Down syndrome specifically, a much lower percentage will have resolution of sleep apnea after adenotonsillectomy, although it's still considered first-line treatment. Here, this was a study that looked at a number of trials and found that only about 50% improvement in OSA from adenotonsillectomy in kids with Down syndrome. So clearly, there's a need for other options, and there can be other surgical options done clinically. So kids who have Robin sequence or other craniofacial differences might benefit from things like midface advancement or mandibular distraction. And then there's other surgeries that are being investigated, like partial tonsillectomy, lingual tonsillectomy, and then we have tracheostomy available as a last kind of resort in severe refractory cases. And then there are medical therapies that we're aware of too, right? So maxillary expansion is one that's been shown to be effective, but patient selection is really important, and that can be really difficult. There's been a number of studies over the years looking at nasal steroids, and some of that I've been involved with at our center. This was one that we published a couple of years ago that showed that there was statistically significant improvement in OSA with nasal steroid sprays, but really not clinical resolution in most of the cases. And again, this is probably not effective outside of more mild OSA. And then leukotriene inhibitors is another thing that's been investigated over the years too that may be more potentially effective too, but black box warning, sometimes people are reluctant to use these. And then we know that there are other medical or non-surgical therapies. So weight loss can be effective, but it's obviously difficult to do and difficult to sustain. We don't really know what the effect of bariatric surgery is in kids. There have been some very small studies looking at that, but mostly in the adult literature. And then as we see more GLP-1 receptor agonist kind of treatments being used in the pediatric space, it'll be interesting to see what that effect is on sleep apnea. I know there was a really good session on that in adults at the sleep meeting last year, and as we see more of that in kids, we'll see if that has some effect because that could have more widespread use in the future. And then hypoglossal nerve stimulation is something that you've probably aware of as now being somewhat available in the pediatric space, specifically in Down syndrome. And the groups that are doing that are looking to utilize it in other groups of kids, younger kids or kids with other conditions, to try to figure out like what the boundaries of it are, what the barriers, and what the efficacy could be. Obviously, CPAP is a therapy that we're all very familiar with, can be useful in all ages, but adherence is always a challenge, right? And so sometimes, having the resources to work on adherence, as well as look at potential risks specific to children. I know you guys do a lot of work with infants, and this was a baby who was using CPAP for many hours a day and started having a lot of skin breakdown. So that's an ongoing challenge in those patients. We use CPAP in our center, even in infants, and we published this a few years ago to show that CPAP can be challenging in older kids, like adolescents or school-age kids. It can also be challenging in infants, but it can be effective really in any population. So we found really no difference in the impact of sleep apnea, both in terms of its efficacy for sleep apnea, and then also its tolerance. Side effects were pretty similar compared with an older cohort. So again, something to think about. And when we're thinking about some of the newer therapies, I think that some of the most exciting work, as I mentioned in the beginning, is being done in the Down syndrome population. So you're probably aware of the Include initiative program through the NIH, which really funds a lot of work in terms of new therapeutics and diagnostics for Down syndrome. And as we kind of talked about already, these kids are at risk for sleep apnea because of a variety of different features, one involving midface hypoplasia. They can have narrower upper airway and small nasal passages. They can have relative hypotonia, relative macroglossia, and then their tonsils and adenoids can obviously be a contributor like everyone else. But I think it's an opportunity to work specifically with this group because the funding is available through Include and also because the community is really receptive to participating in research. So this is just an image from one of our Buddy Walk, which is like an annual event that we have. It's actually next weekend, where we raised funds for our Trisomy 21 Center. And these kinds of programs are available throughout the country and really engages the families with the community of researchers and clinicians. And so I'll talk just about a few studies that are going on now in this area in terms of newer therapies for sleep apnea that are really right now looking in Down syndrome. So one is looking at enhanced CPAP behavioral support. And this is led by Ignacio Tapia, who's currently at the University of Miami. And it's a 2-site randomized trial that's taking place at Children's Hospital of Philadelphia, where I am, as well as at Cincinnati Children's, that's kind of looking to see whether enhanced behavioral support really can help some of these kids with Down syndrome who are struggling with CPAP adherence. And so it's this R6133 mechanism that I mentioned. So in the first part, what they did was really look to see what the family's needs were in terms of this support. So you could just come up with a bunch of things you wanted to include, but this was really trying to get input from the families. So really what they prioritized was trust and patience, and then support. So trying not to rush it and take their time with kids, and then good communication with the medical team, good communication with medical equipment companies were critical in terms of building trust with the families to try to help with these kids with adhering to the therapies. So this trial is just wrapping up now, but what they randomized the kids to, everyone is getting started on CPAP. They have a whole bunch of baseline assessments, but they get randomized to the intervention arm where they have basically a lot of additional contact by the psychologist at one of these two centers. Phone contact, texting, they have all kinds of ways that they can contact. So it's not really any difference with the medical team or the medical intervention. It's really just the contact with the behavioral support. And they have check-ins at the beginning and then every few months with the study team. And at the end, they're looking to see what the adherence is like, quality of life, and some other outcomes. So this study, as I mentioned, is just wrapping up now, and we'll look forward to seeing what the findings are in the next year or so, I think. This study you're going to be very familiar with because you're one of the sites. So this is the DOSA trial, which is looking at supplemental oxygen for kids with Down syndrome and sleep apnea who have been intolerant or unable to use CPAP. So it's a 7-site randomized single-blind trial that's a 6-month therapy of either nasal cannula oxygen or basically a placebo. And the study is hoping to enroll a total of 230 kids between 5 and 17 years old. And looking obviously at the impact of the oxygen on sleep apnea, but also the primary outcomes really are looking at neurocognition and behavior, as well as quality of life and cardiac function. So participants in this trial, once they get through this challenging randomization phase where they have to qualify with their initial sleep study, then they have to be able to have a response from supplemental oxygen and get randomized either to the oxygen with supportive care or just the supportive care arm. They're followed for 6 months, and then they have this battery of tests at the end too to see what that is. So this study has been going on for several years and has a couple more years to go, and it's doing really well, and we're all really looking forward to seeing the findings when they come out. This is a study that hasn't started yet, but is being funded by PCORI, and the lead investigator is at University of Arizona. That's Dan Combs, who is looking at a precision medicine approach for obstructive sleep apnea and people with Down syndrome. So this includes both children and adults. And so he's done some preliminary work that was funded through an R6133 with atomoxetine and oxybutynin, which really can potentially improve airway tone, which, as I mentioned, is one of the potential barriers and causes of sleep apnea in people with Down syndrome. So you have an SNRI and then antimuscarinic agent, and potentially like the combination of these two drugs together could improve airway muscle tone during sleep and treat sleep apnea. So you have this muscarinic inhibition that mediates the pharyngeal hypotonia that potentially could be impacted here. So he had completed a smaller kind of pilot study that only really had like 12 kids. These were all children who was able to complete, but did show a significant improvement in sleep apnea, more in terms of mild OSA, with those who were treated with the study drug. So they had baseline testing, then they did 2 different doses of this drug and found there weren't really significant differences between the dose, but that being on the drug did have an impact versus not being on it. So with these preliminary data, they were able to get funding to do this multi-site trial that's going to start next year, and there's 5 sites that are going to be involved with this study. As I mentioned before, the hypoglossal nerve stimulation is a therapy that's being used more in kids, and so this also had some funding through the Include program that I mentioned. This was primarily through Mass Eye and Ear was the primary site for this study, and they've had quite a few publications that have come out of it. And this is one that was published in Laryngoscope just a couple months ago. And this study found that there was a response in terms of the OAHI in these kids who were being treated with hypoglossal nerve stimulation. But I think you have to be careful and look at these findings. If you looked at the percent who had an AHI less than 10, it was pretty high, like 78 and 72% at the different time points. I think this was 6 months and this was 12 months, if I remember correctly, from the baseline. Now, the mean in the beginning was like 23. So these aren't super severe, but they do have kind of moderate to severe OSA. But then if you look at the AHI less than 5, these numbers drop significantly. So only 36%, 36 to 39% after 6 to 12 months had an AHI that was less than 5. And then if you go to less than 2, it's actually a very small percentage. So I think this is one of the therapies that potentially does have some impact, but it's not a cure rate in 100%. And certainly at our center, we've done a bunch of these and we found that the response is variable. Some kids do really well and some kids don't. The primary outcome of their most recent study is really looking at some of these neurobehavioral outcomes too. So again, sort of separate from just the AHI and how are these kids feeling, and a lot of them do have clinical improvement, significant. And then I'll just mention this study, which is being led by Derek Lamb, who's at in Oregon. And so this is really like a personalized surgical approach. So rather than doing medical therapies, he's looking to see whether we can improve the surgical approach of sleep apnea in kids who have persistent sleep apnea after adenotonsillectomy. So the idea here is to use drug-induced sleep endoscopy, which is being used as part of the hypoglossal nerve stimulation therapy to assist with surgical planning sort of beyond adenotonsillectomy. So what he's doing as part of this trial is trying to see whether doing DICE-directed surgery, so sort of making the decision of what kind of surgery to do, and there could be additional surgical treatments that he's doing, versus just the traditional adenotonsillectomy has a significant improvement. And he has found this with some of the preliminary data that they've done. They've looked at kids with obesity versus kids that have Down syndrome, and they found that there's been a significant improvement in the DICE-directed surgery in those with Down syndrome versus traditional adenotonsillectomy. So again, he's looking at both the OAHI as an outcome as well as quality of life. So this study, I think, is kind of towards the end, but still going on for maybe another year or something. All right, and I'm just going to wrap up for a couple minutes talking about our workforce and potential ways we can expand. So, I've been thinking about just all these things in terms of diagnostics and therapeutics and like how we can implement them, and what are the barriers. And I think one of the barriers is the physician workforce. I think it's, if you go on the American Board of Pediatrics website, and I know this is not the only way, people who are trained in child neurology or other specialties may not certified through the ABP. But you can see that there's only about 393 people who are trained in sleep medicine that certified through the ABP. So it's actually one of the smallest subgroups, I guess, in terms of pediatrics. And I think there's about 7,500 sleep trained physicians total, and only about, if you do the math, 5% of those are trained through the ABP. So it's a very small number. But as we've discussed here, and then if you just zoom out a little more broadly, sleep problems are very, very common in children. I mean, if you're a general pediatrician, it's something that you're dealing with on an everyday basis. Behavioral sleep problems are probably the most common. 30 up to 30% in different age groups could have that. I mean, that's just a tremendous number of children. And then parasomnia is common, maybe up to half of kids. And then we already talked about sleep apnea. So I think there's like a big discrepancy between the demand for managing sleep problems, including sleep apnea, like we've been discussing, and just like the supply of people who have this training. And again, I think that the answer is not necessarily just board certifying more pediatricians in sleep medicine. I think we have to think a little bit more broadly about it.
Chris, can I ask you just one thing about that graph on the bottom left?
Yeah.
Um, I don't think it's showing that fewer people are going into pediatric sleep medicine, right? Because it starts when you could first take that certification, and that's why there were a lot of people
That's right.
taking it. So the problem is that it's pretty flat. But I don't want people to think that, oh my God, look, no one's going into it anymore.
Well, I think that's a good point. But I think that it's also true that not more people are not going into it. So
Yeah,
if you look
that's
at the
right.
number
That's
that are
true. It's not increasing.
yeah, like the number that are certifying by year
Yeah,
is not really going up. I think it's
yeah.
been kind of flat. Like you're right, there's that initial peak once the certification became available in like 2007, 2009, and then maybe the subsequent year, but then it sort of tailed off and it's been kind of flat. I spent some time just like looking at the other subspecialty fields in pediatrics, and many of them are going up, not all of them. You can sort of
Oh,
play around with this on the ABP website, but I don't think that there's been
hmm.
an increase over time in the number that are certifying per cycle. It's been like in the range of like 30 or 40, I think, per 2-year cycle. But yeah, there are more people. It's a question of whether there are more people retiring or more people
Yes,
entering the
that's a
field, right?
terrible question.
Yeah. And then this is just sort of a couple papers that I found that were looking at training programs that are offering a sleep fellowship or sleep elective rather. So like if you're in training and you're interested in sleep, and this was not something I looked at when I was in training in pediatrics, but you can see pediatrics is like 35% offered an elective, which actually I was surprised it was that high because I feel like this is not something that at least a few years ago was being offered that much. But it is definitely lower than psychiatry, critical care, neurology is the highest really, and then family medicine. ENT is definitely lower, but this is a pretty niche area. And then if you looked at the trainee participation in sleep-focused research, again, pediatrics, oh, this got cut off, I think. Oh, yeah, no, pediatrics is here in the gray. It's again one of the lower areas. So, pediatrics is not an area where people are necessarily being offered a lot of electives. They're not doing a lot of research. And then this was like a global study that was looking very broadly at people who had all different kinds of training in general pediatrics, sort of family medicine, really internationally. And there was definitely like a desire of these trainees to have more education in terms of sleep. And they asked them like, what about sleep are you interested in? And again, this is like very variable. Like none of these were super high, but a lot of it was behavioral sleep issues, interventions and treatment, sleep and neurodevelopmental or kids with intellectual disabilities, infant sleep, adolescent sleep. So there's a lot of different areas here, but I think that these were not really being addressed in these different areas, and most of them kind of felt like they wish they had had more training in sleep. So I think there's the desires potentially there, but there's just not a lot of infrastructure to make it available. So I think something like this maybe is what we need to consider as just like with partnerships. So between those doing clinical work, that expands well beyond just like physicians, certainly to include all the different team members that are providing clinical care. That includes psychology, includes nurse practitioners, physician assistants, even social workers, RNs, and then thinking about more broadly areas. You have the pediatrics, but also other subspecialists in pediatrics that are not trained in sleep medicine, and then our colleagues in adult sleep medicine, kind of all overlapping to sort of support the needs of all these kids. And then, in addition to the clinical work, thinking of the overlap with the research, of thinking of clinical partners as research partners and thinking of researchers as partners with the clinical care. And then I think, again, Down syndrome is a great example of this, but where we can think about advocacy groups and policy groups coming outside of the medical field that can help sort of partner both in terms of funding, in terms of messaging, and things like that. All right, well, I'll stop there and just sort of summarize by saying that as we've discussed, sleep apnea is common, lots of impacts on children. Currently, polysomnography is really the gold standard, but there potentially are some newer therapies that could be available in the future. We'll have to wait and see. And as we know, adenotonsillectomy is sort of the first line treatment for kids, but there's a lot of new and exciting treatments, I think, coming out of the Down syndrome world, which hopefully will help those families in that community, but then eventually may become available to other children as well. And I think we really need as a field to sort of think about all working together and including very broadly speaking our partners across the healthcare system to really expand our opportunities for care and for research in this area so we can leverage things like these multi-center partnerships that we have through DOSA and CHAD and these other trials to try to really improve the science as we can help these kids. And this is just thank you to my different collaborators at CHOP and beyond, and the different foundations and NIH that have supported the work that we're doing. So I'll stop there, leave some time for discussion. And I'm going to stop sharing just because I can't see anybody.
That's great. Thanks, Chris. I don't see any questions in the chat right now. I don't know if you want to just go ahead and unmute. Go ahead, Ron.
I have a quick question, and I have to run physically to another building for a 2 o'clock obligation. But I thank you very much. That was great, and really shows some of the exciting things going on in pediatric sleep now. But I wanted to ask you more about the pipeline issue. We have a lot of trainees like this year. I think we have 2 from family medicine, 1 from med peds. And the question is, to what extent are they well positioned or recruited, or can they partner with pediatric sleep programs, especially when they're based in pediatrics? As I think if we took advantage of that possibility, we'd have a lot more available for pediatric sleep medicine.
I completely agree. I mean, I think we don't want to turn anybody away. I think regardless of training, family medicine is a great example. I mean, I worked closely with a colleague, Lourdes Del Rosso, who was trained in family medicine and does some amazing work in sleep, and she's been on the West Coast for a number of years, but really become a leader in pediatric sleep. And people like yourself, Ron, I mean, people that come maybe from a different angle, I think have a lot to offer and can really help, provide outstanding care to kids. So I'm definitely somebody who anybody I think who's interested, regardless of your background, even if you're not trained in sleep medicine, I think there's ways to partner. So I think it's getting the message out and just trying to have a big tent and open it to everybody.
All right, that's good for our fellows to hear.
Great, thank you. Fazia?
Yeah, thanks, Anita, and hi, Chris. I think besides that, I think it's like this is a thing for the ABP also to think strategically, but that's to Ron's and your point about what is our pipeline and how should we encourage more from the ABP perspective. But going back to the AIDSAT question, and I know the guidelines are, and I think that is where we worry about long-term, like learning lessons from the adult side and what does it mean for pediatrics. Like in-lab polysomnography has been our gold standard, and I think what the message goes out to and what we worry about is what does the average pediatrician slash practitioner on the outside who doesn't keep up with the guidelines or doesn't read the guidelines really think is, if you get a negative home sleep apnea test, the message that they often deliver is it's a negative test, hence you do not need to follow up with an in-lab polysomnography. And the tertiary care centers are pretty careful in saying negative tests, go on to repeat polysomnography, but then the insurance companies and guidelines go out to is you get an AIDSAT, and then that is your first line, and then all of these things are later on gets mandated that AIDSAT. And I think that is where the worry of pediatric practitioners is this going to go down the route of adult home sleep apnea testing or not?
Yeah, I think that's a really important point, and it's one that I think most people share. I think that we recognize that it's not a one-size-fits-all solution for every family, and there's so many individual circumstances that would, make if it was even something that was clinically available, make it not appropriate in certain cases. And I think we would want to be really careful that it's something that the clinician with the family would have to make that decision, that it's the best test for that specific person. And I think it is knowing sort of the limitations of different types of tests. I think the major difference that we have in pediatrics, and this gets a little bit to the workforce issue versus adults, is like 90% of kids who get treated for sleep apnea never have any objective test. And that's like almost zero in adults. Like you basically can't get on CPAP, which is the first line treatment in adults, without a sleep study. Like almost nobody can, right? But in pediatrics, like that's by far the default is no test, nothing. So that you're not competing with polysomnography. You're competing with an ENT surgeon who sees a kid, doesn't do any testing, and decides to do a surgery in that kid. And I think that's the huge difference that we face in pediatric versus in adult medicine. And I think that I've no doubt that like all of you can provide, expert review of a sleep study and, really know how to interpret that. But the challenge is that 90% of those kids will never make it to your lab and never get any kind of testing. And the question really should be, I think, like, is it fair to all those kids that are out there that don't have any, just can't get the test, or the test is so delayed by many, many, many months that like the treatment is sort of withheld in those cases. So I think it's a different paradigm, and there's just not enough of us to read, if we had to increase tenfold the number of sleep studies that we have, whether they're home sleep studies or in-lab sleep studies, it's going to be a real challenge. So I think that there are some similarities, and there are definitely things we should learn from the way that the adult sleep medicine, adult sleep apnea evaluation goes. But we have to recognize that we're sort of in a different area, and we would need things to be, pediatric focused, I think, if we were going to do something like this in kids.
Great, thank you. Lisa?
Yeah, I guess, piggybacking a little off of that, I guess I do also share some of those concerns about like the real world insurance. Like, is this setting us up for just delaying like the ultimate in-lab test that they might need? But specifically, I just had some questions about your studies. Is my understanding that mostly you've been doing the type 2 like EEG home sleep apnea tests, because I don't think our center even has those, and I wasn't sure if you knew like how accessible that would be, or is that a barrier? Because they still have to, I would think, be like hooked up by technicians and go to like a sleep center that knows how to do that, and pediatric people. And then also if you could comment on like, are we just foregoing like CO2 monitoring as a standard of care assessment as part of sleep studies for children?
Yeah. Yeah. Coming into the lab and getting wired up for a full sleep study is a huge limitation. Like, and to scale that up is like not going to be easy. And I'm not even suggesting doing that. I'm just doing research studies. This isn't like clinical care. And yeah, so it's easy for me to do it because I have a sleep lab and I've got like research techs that can do the setup and all that. But to scale that up to try to meet the needs would be very difficult. And it wouldn't even like probably be, you could probably do it at your center because you have a big sleep center, but a lot of places probably couldn't do it. I think the real benefit of doing it that way is so that you have all the data and you can say, okay, well, let's look at this without the EEG, let's look at this, without that. And that's kind of ultimately, I think, what we're going to do with some of the data we have, like from the home environment. And also to show like it's not that easy for, like I said, for a lot of parents to do it. Sometimes the data that comes back is not that great. There's a lot of challenges with doing it. And then, sorry, your second question was about
Oh,
the
sorry, just like CO2.
Oh, CO2. Yeah. There's lots of other limitations too. Like in Down syndrome, like in the first study, I didn't show this, but like 20% of those kids had like sleep-related hypoventilation. And we didn't pick it up on any of the home sleep studies because we're not monitoring CO2. Like doing CO2 monitoring at home during a sleep study just like is very hard to do. Now you're adding even more equipment. How reliable is it? There's other groups that have tried to look at that and it's really tough, like in neuromuscular population. You're missing that. You're not only missing that, like you're missing sleep-related movement disorders. Like this kid's tired because they're waking up a lot at night. Okay, you rule out sleep apnea, but how do you know they don't have like PLMD or something? You're not assessing for that at all. So there's a lot of limitations. And again, that's with like this full PSG, setup that we're doing. We're not doing CO2. We're not doing limb movements and other things. So um, home sleep testing is not an alternative to polysomnography in most of the cases because there are other things you can evaluate in lab polysomnography that like really nobody has looked at all in kids for home sleep testing. So there are a lot of limitations to it.
Thank you.
Great, thanks. Brad?
Hi, thank you so much for that presentation. My question was, you mentioned, I think if I heard correctly, that you guys use a different scaling criteria for mild, moderate, severe OSA based on the AHI. What is it that you guys use, and I guess what's the difference? Or
Yeah, I mean, there's just not a lot of data in kids with any kind of scoring system. And this is true even to some extent in adults, right? That like, okay, if you use the threshold of 1 for OSA, 5 for mild, 10 from, that's just counting by fives or something, but that it really relates necessarily to specific outcomes. And so we use like a slightly higher, so it's like we'll use like 8 for mild and then like 20 for severe as like our cutoff for mild, moderate, and then moderate to severe. We had done a literature search years and years ago, and we did some methodology that I don't even remember to kind of come up with those. But I also think that that's sort of loosely accurate, but I don't know, probably not the best either. I think some of the important thing is like knowing the really severe ones that probably need to stay in the hospital overnight, after they have endotonsillectomy. And then trying to assess like which kids really need to be treated. I mean, I think this is especially challenging after PATS because those kids had like really mild sleep disorder breathing. In some cases, wouldn't even qualify for an OSA diagnosis, but then once they got treated, they had improvement in their behavioral symptoms. So this is where I think polysomnography, like when you got, when those of you who are sleep physician, when you review that, like you're not just getting that number, right? You have all the other information that you're sort of feeding back to the person who ordered it. And then if you actually had the chance to see that patient in clinic too, now you can match not just the AHI, but all the rest of the information in the sleep study with the clinical picture to try to decide like, okay, do I want to treat this kid or not? And if it's super severe, you're probably going to treat them. If it's more mild and they don't have a lot of symptoms, maybe you choose not to. So I think, focusing on these thresholds of mild, moderate, severe, even whether they have OSA or not, like what is that cutoff? Is it 1? Is it 2? Is it 2.5? Is it 5? Like there's some issues with doing that. It's just my own opinion.
oh yeah, thank you so much.
Great. Any other questions? Okay, great. Well, Chris, thank you again for a fantastic presentation. I think we all
Thanks.
learned
Great
a
to see you
lot.
guys.
Yes, great to see you as well. Take care.